like to go ahead and give a little detail of me, or would you like me to go ahead and do that myself?
You can go ahead, Lucy.
Sure. Just for all of you that may not be familiar with me, my name is Lucy Reimche, and I'm the managing partner of FHG Partners. We're a CPA firm that pretty much focuses on FQHCs and FQHC lookalikes. I started my career with Ernst & Young 25, 30 years ago, and I've been pretty much in healthcare from the private area hospitals to starting FQHCs to consulting and auditing FQHCs. So my heart is very close to what you do in your mission, and I'm also a reviewer for HRSA, so I'm able to go out and serve the Bureau of Primary Care through that process and help you all to be compliant with these program requirements. So today we've got quite a full agenda. It's going to go pretty quickly, but there's a lot of material to cover. So my speed will be relatively fast, and we will have an opportunity for answers and questions at the end, and also any subsequent if you need. But today's agenda, we're going to go over the sliding fee discount program, which of course all of you are familiar with, program requirement number 7. And we'll discuss the new policy notice, which is the 2014-02. We'll go through understanding the role of the board and management so that it's clear on what they do versus what you as management does. And then, of course, we'll go through developing and implementing the policy and procedure, and also just sort of how can you test and see how compliant you are. And then we'll open up for questions. So with that, I'll start with just an overview. All of you are very familiar with your program. You've been doing this for a while, but as you know, Section 330 of the Public Health Act allows you as an entity and provides for you to ensure that you are providing medical care to the underserved community. And in your case, of course, the migrant farm workers is a significant portion of what you do. And of course, to comply with that, you've got 19 program requirements, and as we stated, number 7 is the sliding fee discount program. I will tell you from my experiences of doing these reviews and talking with other consultants that do them, program requirement number 7 seems to be one that always has an issue. It's just so difficult to try to implement and to interpret. So this pin and this training today will hopefully help you to accomplish that, and you can be one of those that does not have a finding in program requirement number 7. So with that, I'll just start off with what the Bureau's primary purpose for this is, and that is really the intent of the sliding fee program is to minimize the financial barriers to care for patients that are below the 200% of federal poverty guidelines. So they want to make sure that patients are able to access care and obtain that care and not have a financial issue to deal with. So that's the primary purpose of the sliding fee program and the discount from the Bureau's perspective. So the sliding fee program has a bunch of items that it needs to accomplish and things that go into it. So it's not just a one-item type of thing. And one of them, of course, is you've got to have a fee schedule. You've got to start with your fee schedule, also known as your charge master. And you've got to have a corresponding discount relating to those for the eligible patients. And then, of course, you have to have board-approved policies and procedures that ensure that you can implement that policy. And, of course, your billing and collection policy also ties in with your sliding fee. So PIN 2014-02 also addresses the billing and collection component of it. The sliding fee discount program also says you need to make sure that it is applied uniformly to all patients and to all services within your scope of your project. And then, of course, it is based on the patient's income and family size. And that is determined by the board. Your board defines in its policy the patient eligibility criteria for income and family, and we'll go through that in further detail. It also discusses, of course, that you need to ensure that your patients that are below the 200% of the federal poverty line, especially at the 100%, receive either a full discount or a nominal charge, and we will discuss nominal in a little more detail as well, and that you have at least 3 discount classes between the 100 and 200% of the federal poverty guidelines. So with that, we'll go to our first polling question here. Does your center currently have an updated sliding fee discount program, and are you familiar with it? Arben, do you want to take over from here?
Hi, Lucy. Can everyone see the poll screen? I just launched that poll question. Okay, great. Okay, so at this time, if you would select your answers, A, it says yes, you have current SFDP. No, you do not have current SFDP. Yes, I'm familiar with how it works, or no, I'm not familiar with how it works. And at this time, you can select one of the 4 choices.
And this just sort of gives us an idea of where you're at as a group, and hopefully it'll help me to focus in areas that you need more than others.
Okay, Lucy, so majority say yes, they're familiar with how it works, and that's 56%. 33% say yes, I do have a current SFDP, and 11% are not familiar with how it works.
That's interesting, and that is probably reflective of a combination of audience that we have. So we've got a variety of you, from CEOs to CFOs to controllers to QI staff. So welcome all of you, and I think hopefully we'll be able to cover all of the areas, and by the time we're done you'll be familiar with it and be able to ensure that your organization is compliant with it. So thank you, Audrey. I'll move over and continue with the presentation then. So let's start with the new PIN, which of course is new and not new because it was issued in September of 2014, and it was effective upon issuance. And the purpose of the PIN was to clarify the sliding fee program. As a lot of you are probably familiar, this PIN has been in draft for a lot of years, so they finally came out with the clarification, and I think it definitely helps to clarify some areas, and it also sort of has expanded on some areas where it was somewhat silent or just not very clear as to what the centers were required to do. So we're going to go ahead and go through and try to identify for you some of the highlights of the PIN. And the primary one is that really the eligibility for discount is based only on 2 factors, income and family size. There can be no other factor. And an example of this is many times the centers would have this program only eligible to patients that was self-pay, and that of course would not make this compliant because it's only income and family size, regardless of if they've got a payer source or not. The sliding fee program must also be available in the appropriate language and literacy level, and of course targeted to your specific population. And in your case, of course, you've got a large population that may speak another language, and that the literacy level may not be at the same level as maybe another group in a more in an area that may be a little more fluent or whatever it may be. So it's very important for you as an entity to ensure that your program is at the literacy level that your patients can understand it. And again, this is something different. This is not something that patients are necessarily familiar with in their day-to-day lives, so of course it's more important to focus on them understanding it in a very simple way. And then of course there's also an expansion on the board responsibility that I think the PIN clarifies, and there's 3 areas that it definitely ensures or expands on as far as the board's responsibility. Besides them approving the policy, which was always sort of there in before, they need to now periodically review and evaluate the operational procedure of the policy, and we'll go through that in detail. And they also need to assess the effectiveness of reducing the barrier to care, because if you recall, the objective of HRSA is to ensure that this really minimizes any financial barrier for the patients to obtain the proper care. So the objectives of this PIN was to ensure that. And then of course they also have to make sure that this PIN is your policies and procedures are appropriate for the health center and its community. So it's specific to your community and to your population that you're serving. And in your case, you've got a very unique population that have specific needs that need to be considered. The PIN also says, that you have to routinely ensure that your staff are trained and that they implement the sliding fee. And of course, this you probably have done, but it's a good idea to just ensure that it may come into more of your training, scheduled, regular, new employee training, as well as sort of annual training as a process, and not just sort of as, well, we need to do this and we haven't done it for a few years, but rather that it's part of your educational part of training on an annual basis. And then, of course, the policy must address a couple of minimum items, and of course, the eligibility of the patients, the criteria, determining what that income is, defining what income is to be included, and what is considered family size. And those things seem obvious, but they're not. When you're talking about income, what is going to be included and not? Is it going to be gross income, net income, etc., child support, etc. So there's a lot of things that need to go into defining that. And again, the PIN is allowing you as an entity to define that. And then the same thing with family size. You've got to determine if you're going to include which family members, or is it just everybody that lives in that household? So you've got to define that. You've also need to ensure that it determines the frequency of the reevaluation. So if a patient's eligible today, is that good for 6 months? Is that good for a year? And then, of course, the documentation and verification requirements. What are you going to accept as an entity as appropriate documentation to verify that the patient is eligible? And again, that is something you decide as an entity. And then, of course, it's got to have the structure, the specific structure of the sliding fee discount, on what percentages for what categories are going to be included. And then, of course, it also includes billing and collection process, as well as some provisions for waiving any fees or the nominal charge. And again, these two, billing and collections and the provisions for waiving fees and nominal charge, are actually typically in your billing and collection policy, so we won't be going through those in detail. We will be focusing on the sliding fee, but the PIN itself does address those two additional items, number 5 and 6 as well. In addition, it also gives you some alternative mechanisms for determining patient eligibility. So there are circumstances, and especially in your circumstance where you've got your farm workers, migrant workers, you may want to have a self-declaration. Patients are moving from one area to the other. They may not have all of the documentation with them that there would be in a regular community clinic. So again, you want to be sensitive in determining what information you need, and you are able to, and the PIN does allow you to have alternative mechanisms for that determination. Also, you've got to establish the collection of the nominal charge. How are you going to collect that? And if you're going to send the patient to bad debt, so on. And again, that one, like I said, usually goes into your billing and collections policy. The PIN also allows you to have multiple sliding fee, and you've got to obviously have appropriate justification for those. An example of that would be if you've got both dental and medical, that you would have a different sliding fee for your dental versus your medical. And then, of course, the sliding fee also allows you to have other discounts for other specific items such as supplies and equipment that may be outside of the sliding fee. And an example of that would be if you do offer medications, if you do offer specific dentures as an example, that type of thing, that you can have those items carved out and provided at cost to patient, or at a discount as you choose, as we'll discuss in a little further detail. And then other provisions of relating to the billing and collection that the PIN clarifies is, payment incentives, grace periods, payment plans, refusal to pay guidelines, those types of things. And again, that would be a whole session in itself, just the billing and collection component of it. But I will just stress on the payment incentives, if you do offer it, keep in mind you have to offer it to all patients, including your sliding fee patient. So if you have a prompt payment discount, that has to be applied to your sliding fee patient amount as well. So that is important to keep in mind with number 5 if you do offer a payment incentive. And then the PIN also says that you need to ensure that all services within the health center scope of project are included in the sliding fee program. So you have to define that in your policy. And then, of course, the unique characteristics of the target population that we talked about. So it's important to identify and to be specific to your specific patients, such as your farm workers and migrant workers, and the area to consider, and to consider those things when you're building your policies and procedures, that your population is unique, and that those characteristics of that population are considered as you build your operational procedures and your policy in order to ensure that it's not a barrier to the patient's care. And then, of course, you want to evaluate your policy's effectiveness annually. Of course, that's a best practice. You do have to update your federal poverty guidelines annually because those do come out. But as far as the effectiveness of addressing the barrier to care, you can do that every 3 years. Best practice would be annual, and since you are doing your federal poverty guidelines annually, it may behoove you to include those together and do it at the same time. And we will discuss that in much more detail as far as how to go about doing that, because I think that's an additional item that you haven't necessarily documented in the past. You may have done it, but not really documented it in the past. And then the PIN also goes ahead and identifies the individuals and the family members' annual income between 200% of the federal poverty guidelines to not be eligible. So here I want to caution you, because a lot of times what we see as an error on the sliding fee is that it excludes the 200% patients. So the guidelines is that it's above 200%. So 201% are not eligible. But the 200% of the poverty guidelines patients are eligible. And however, if you've got patients that are at the 201% or the 250%, you could offer additional fund sources that you may have. So you may have another grant or another type of funding venue that those patients may be eligible for. And of course, you can specify that. And that would not be a violation of the PIN. And then the additional item that, of course, is very important is that if you do have the patients at 100% or below, that they really receive either a full discount, so they pay zero, or they pay a nominal charge. And this is really important because a lot of times what we'll see is minimal charge, but really the HRSA requirement is a nominal charge, and they define nominal charge as an amount that is not covering cost, and it is nominal from the point of view of the patient. So it is not a barrier to care. It's nominal. It's insignificant. It's minor to the patient. It is not a burden to the patient. And of course, now the PIN requires you to evaluate that you are ensuring that it's not a barrier to care, that it is considered nominal from the patient's perspective. So that, again, is something that's added and clarified in this PIN that was not there before. So let's talk about that nominal, because again, it's not a minimum fee. It is not a nominal charge. It's not a co-payment. I'm sorry, it is a nominal charge. It's not a nominal fee, a minimum fee, and it is not a minimum charge or a co-payment. Sometimes in the policies we'll refer to as a co-payment, but that is not what the purpose of this is. It must be less than your fees, and it must be less than what the patient in the first payer class of your slide would pay. So you're required to have at least 3 discount classes, and here if your nominal fee, for example, I'm just going to throw out a number. I'm not saying this is any appropriate number, just a number here. Let's say your nominal charge is $20, but your patient between the 100 and 120% will receive a discount, and based on the lowest level service that you have, that discount with the discount, the fee would only be $15. Now that would make you non-compliant because your nominal charge for your patients below the 100% is 20 in this example. So you would have to make sure that your category for your first slide is above that $20. Otherwise, you've got a violation here of the requirement. And of course, that nominal fee needs to be a fixed amount as opposed to a percentage. So it needs to really be easy for the patient to identify, such as a $5, $10, $15, $20 type of thing. It must not, of course, reflect the true value of the services. That's why it is considered nominal. And then, of course, the sliding fee discount must apply to all services. And again, this is something that needs to be defined in your policy on the services that it covers. So if you've got a charge for it, it needs to be included in your fee schedule. And of course, it can be established based on the type or the mode of delivery, because you can have different modes of delivery. And for you that are not familiar with Form 5A, that is basically a form that is used for HRSA to monitor and to determine what is included in your scope and what is provided by you as an entity, what is provided by you through an arrangement in which you are paying for the services, which is column number 2, and then what is being provided by referral. So you don't do it yourself, you don't pay for it as an entity, but you refer to a different provider for that, and that patient pays for it to that provider, and that would be column number 3. So for those of you who are not familiar with Form 5A, this is a really important document, one-pager that you need to have as you start developing your policies and procedures on the sliding fee to ensure that you are meeting the components of column 1, 2, and 3 and how to treat each one. And HRSA and this new PIN has definitely clarified what is included and what needs to be included and specified in those for the sliding fee, and we'll go through that, and that definitely, I would say, is probably the biggest section, one of the biggest sections that has been clarified for you under this PIN, and we will discuss that in much further detail. The next item here that the PIN has also added to the clarification is that you can have multiple sliding fees, as we discussed, and it can be in different modes and services, obviously, of delivery. So, for example, let's say you may have a mobile van that goes out to your farm workers in a certain area at a certain seasonal time. That would be considered a different mode. So there you could have a specific sliding fee that would be specific to that mode and to that population. But of course, anybody that walked in at that mobile clinic would be provided with that same sliding fee. You couldn't differentiate between farmers and non-farm workers, as an example. You'd have to offer to everybody based on just that mode of delivery. So the mode of delivery is the factor that you can have in order to have a different sliding fee or multiple sliding fees. And then, of course, as we talked about the Form 5A regarding to you as a center having to have formal written arrangements for services that you yourself do not provide or pay for, but that you refer out. And here the PIN states that you as an entity needs to ensure that the health center's patients receive the same sliding fee discount program requirements and criteria that they would under this PIN. So this one, of course, opens up a whole bunch of discussion, and we will go through it in much more detail on addressing, some of the processes that you can go about on how to deal with that. Because again, the objective of HRSA is to minimize the financial barrier to care, but this one, of course, is one that is a little bit of a challenge for centers, and that's something you may not have in place currently. And with that, let's go to poll question number 2. So Aubrey, if you could open up, and that polling question is, how many of you think your current sliding fee policy and practices meet the PIN 2014-02 requirement?
Okay, looks like Lucy, 64% say yes.
That's wonderful. I think we've only got about 21% that says they don't, no, that does not meet. And there's about 56% of you that have voted, so just a little bit more than 50% of you have responded. So that's excellent. You've either had a review or you've been very familiar with this PIN, so that's excellent. And hopefully, if there's anything in in this training that can help you add to that or to monitor it, that would be where the value added would hopefully be. And for the 25 of you that don't know and the 14 that are not sure, hopefully you will be by the time we're done with this training. So I'll move ahead and go on to defining the roles between the board and management. And again, I think this one's very important because there are additional roles that the board needs to have that they maybe have not had in the past. So I want to clarify that and help you. You may also be able to use these slides as you do some training for your board on what their roles and responsibilities were. So part of the objective was also to provide that for you as a tool to provide to your board. So with that, we'll start off. Obviously, their responsibility is to approve a sliding fee or charge master. So that is not new. That's something that had to do in the past as well. So we want to make sure that you are that the board is approving those, and that those services are included as part of the scope of the project, and that those fees reflect not only your cost but also your local prevailing rates. And here I usually recommend that you make sure your policy, and this would be in your billing and collection on your sliding fee charge master component of it, that you are defining the flexibility that you have to ensure as management on what you can change and not change without having to take the entire charge master back to the board. And that's important because there's always some CPT codes that are being added, and also that you have to be sensitive to the local prevailing rate. And an example here as well that I'll give you, for example, now with Medicare paying you on a PPS rate, you may be getting 80% of charges or what they've determined to be your rate, cost, PPS rate. And it may be that your charges are lower than your PPS rate, not reflective of your costs, so you'd be getting the lower of. So you'd want to be able to adjust one or two of those items without taking your full charge master to your board. But they're required to approve that charge master. So at least every 3 years, obviously best practice is annually, but at least every 3 years that your full charge master will be approved by your board. The second requirement that they have to do is obviously approve your sliding fee billing and collection policies. So they've got to ensure that they are doing that. And again, like you said, most of you, 64% already meeting this, and probably even your 25 and 14% are also meeting this because this has been part of what has been required in the prior understanding of the sliding fee as well. But the additional responsibility here that is maybe clarified a little further that wasn't, is that the policy needs to now also ensure that it is not a barrier to care from the perspective of the patient's ability to pay. So they have a responsibility now to evaluate that, to determine that. And in order to do that, they've got to do an additional process that you may have not done in the past, some form of periodic reviewing and evaluation of that process, and also the effectiveness of it. So it's not just we've got a policy, we've approved it, management is implemented, and now the pen is saying, as a board, you need to ensure that it is not a barrier to care, because that's part of your responsibility. So here, management needs to assist in that, and I'm going to give you some suggestions and some ideas of how you can do that, and to ensure that you've got that written down in your policy on how you're going to do that. So this is definitely an expansion of the role of the board on the sliding fee policy and their ability now to oversee it. And typically, of course, the board is responsible for policy and procedure, not for operational involvement. But here the policy is adding that a little additional responsibility to ensure that the board is evaluating it from the operational process as well. And then, of course, the very important piece, which I'm sure you're all doing already, is that it is updated annually for the federal poverty guidelines that usually come out in January and February of each year. And I'm sure you're all doing that already. And so it is important to probably just update your entire policy and your evaluation process with that at one time so that you don't miss out on it. And so that's the role of board. Now the role of management, your role is to develop the schedule of fees, your charge master, and ensure that it includes all of the scope of the project services that you're providing and that it covers cost. And of course, covering cost, you want to look at your UDS is a great tool for that. So if your cost to charge ratio doesn't quite cover it, and it's not at least about 1.12 per the UDS 2013 number. It's about 1.25 typically for the FQHCs nationwide. So again, you want to ensure that that's there, and that's a tool you can look to see if you are covering. And then of course looking at what your Medicare PPS rate that they've just provided for you, and ensuring that your lowest level of service is going to reflect that cost. And keep in mind your PPS rate is inclusive of a blended rate. It includes a variety of services, from a nurse walk-in visit to a procedure. So of course it's got a variety, it's a blend, it's an average. So if your typical 99213 code for office visit established patient is about $120 on your fee schedule, and your PPS rate is 110, then of course you've covered there, or at least at 120, somewhere in that range. Of course your average charges are going to be more than that. But you do have to, in your billing and collection policy, define how you're going to actually measure that and evaluate that. The other thing is management role is, of course, that you've got to implement the policy that the board approves. So implementing that is a real important component of what management does versus the board. And then, of course, the training. And as we know, sliding fee, it never seems like you can have enough training for staff. But this is sort of an ongoing process that you need to continue to do as management. And as I recommended, include it in your in your annual renewal when the employee has the evaluation, to do an update on that training, whether you have a self-guided training process or whether you have one scheduled, and then of course for any new employees. But the key here is to document that, to have that available so that you can show that you're providing the training and that those employees are being updated on the sliding fee. And then of course a very important one that we see usually a great policy, procedures, staff is trained, and then we'll go into their system, into your systems, and what we'll find is that the sliding fee scale hasn't been updated on your system because that was your IT person that no longer was here, and they established it many years ago, and the fee schedule and policy has not been updated in your system. So right there you become non-compliant because of that one little section there. So of course part of your process when you implement the sliding fee and you update and get a board approval is to ensure that you're also updating it in your system. And then, of course, you're monitoring that compliance with that sliding fee and that you're obtaining feedback on the effectiveness of that. And here the important piece for management's role to ensure that you're obtaining feedback is to determine the effectiveness of that sliding fee and giving that feedback to the board. So you can accomplish that by obtaining that from your staff, from patients, from referrals, those types of things. A number of those can help you to assist to accomplish that. And then, of course, making recommendations on the necessary updates of the sliding fee and your charge master. Of course, you as management are the ones that are really determining, does this make sense, and what should we be assisting and helping provide the board. They're not going to know that. You've got to obtain the information and the feedback and articulate that in a way that they can communicate and understand that. And then, of course, ensuring that you're in compliance with all laws and regulations. You want to make sure that if you have a sliding fee policy and you've also got a contract with Medicare that doesn't allow you, for example, a managed care company to waive a certain amount of fees or a certain amount of deductible that the patient may have, you'll want to make sure that you're not in violation of any of those. So that sort of ends the component on how whose roles are what, and what management does versus the board. And next we're going to go on how to develop and implement policies and procedures. Is there any questions at this point here? I think we've got time enough that we could maybe break up and start to ask if there's any questions in the pipeline. Auburn, could I ask for your help there?
Sure. At this moment, if anyone does have a question, you can click on the hand feature, and as soon as we see that the hand goes up, we'll unmute you so you can ask the question. Or if you prefer to put it in the chat, you can do that as well.
So the question that I saw coming up was, could we clarify? Auburn, I may have to ask your help because it went away. What was the first question that came up?
This one says, can you clarify a point about having a separate SFDP for part-time clients? Clinics, I'm sorry.
Clinics, part-time clinics. So you may have a satellite in that example where it's 20 hours or less. And so that would be a separate venue. I'm assuming, so if you are providing a separate venue for that, you may have a separate one there if there's a specific reason. So a school-based, for example, or one where you're going out into the field, for example, to take care of those patients. So it's not a full clinic, it's just a satellite. If it's mobile, that type of thing, then that would be acceptable, yes. You just have to make and write down your justification for that separate sliding fee. Does that answer your question? Arben, is there any others? I'm not able to actually see here.
Yeah, I don't see any. I don't see any more questions.
Questions. Okay.
Take a look if.
All right.
Yeah, we can move on.
Oh, there's one. Yes. Okay. Great. Let's see. There's one from Amy. I thought you couldn't have sliding fee scale based on patient population. Amy, that is true. It's not based on patient population necessarily, but basically on the mode of delivery of the service or type of service. So you cannot say for these patients, so I'm going to use that example of the school-based. For the school-based patients that are farm workers, we're going to have one sliding fee, and for the school-based patients that are not farm workers, we're going to have another one. That you cannot have. You have to have the same one. So regardless of who that patient is, they walk in, they have to have only one same sliding fee. There was another question that came up here. I don't know what happened to it. Arbor, I may have to ask your help on that one.
Yes, it was from Amy. I thought the mode was only, okay, one moment. I thought the mode was only referring to those columns on table 5A. And
okay, so let me, and maybe I'll have to take that question, Amy, after, because I think we probably need to talk a little bit more through it. So we can definitely do that. I think there's a little more discussion that we need to probably have, and I need to clarify exactly where you're coming from in order to appropriately answer you. But I'll go ahead and go to the next question, and then Amy, we can maybe talk afterwards on it. So the next question was, Auburn, can I ask you for the next one?
How does your sliding fee scale apply to referral voucher providers?
And so for referral providers, you're actually paying for that service. So you are providing the discount. So you would just document that or be part of your policy. So that would be Form 5A, Column 2, where you are providing the service and sending the patient over. You're paying for it. So you are offering that slide and you're paying for it. So you're fine there. You would just have to articulate it in your policy. Next question.
Okay, Terry says we have a migrant voucher program that finds it very difficult to meet these requirements because we are dependent on other providers.
That's a very good question. I really think one of the objectives of HRSA was to ensure that there was, expanded care for these patients and that it wasn't barrier. But from a practical point of view, all of us know that this is really just definitely a challenge. We're going to discuss it a little bit more, and I'll definitely be making some recommendations that you document, the challenge, because a lot of these providers, they don't want to sign anything or be compliant with the sliding fee program that has these requirements from HRSA that they didn't sign up on. They're not getting federal funding, and they don't want to sign up. So there's definitely some issues there that may not accomplish the objective of what HRSA had wanted, but this being relatively new, I think the feedback maybe hasn't got back to the Bureau on this. So it will be very important for you to document those, and we'll talk a little bit more about it as we start developing the policies and procedures and we get to that referral section. Take maybe one more question and then we'll move along.
Sure. This one says, with the nominal charge fee, and the minimum fee needs to be at 20.
I'm not sure if I understand the question, but no, then the minimum shouldn't even be used. If you have that word in your policy, you need to sort of get rid of it because that will immediately almost make you non-compliant. It's a nominal fee, and they define nominal as an amount that is insignificant somewhat to the patient. From the patient's perspective, they're not going to not get care or come and see you because of that nominal fee. It needs to be nominal from the patient's perspective. I don't know if that's $20 in your case. It may only be $5, but that's something you as an organization need to make that determination. We will be discussing a little bit some of the ways you can accomplish that. And of course here they're adding, the pen's adding where really your board is responsible for ensuring it's not barrier to care. Okay, I think we'll go ahead and maybe the questions that we have that haven't been answered, we can try to take them at the end. And we'll go ahead and start on developing and implementing the policies and procedures. Arben, is there any comments or notes that I need to be aware of? It's very difficult because obviously I don't have the leisure of being able to see you face to face. So.
Right, no, everything's going well. I don't see any additional comments or questions, so you can move on whenever you're ready.
Okay, great. So really, at the end of the day, it's developing a policy and procedure that really is applicable to your patient and your center. A lot of times, what I'll see is that someone has adopted a policy and procedure that is someone else's. It's 3 or 4 different clinics cut and paste into it. There's conflicting information in this policy, and it's not specific to the center. So real important is that you develop something that is specific to you as a center. So to accomplish that, there's obviously more than 2 ways, but one of the 2 that I'm going to give you here is either you take your current policy and you evaluate it to ensure that it meets and has all the requirements of the 2014-02. Good percentage of you already said that you think your policies do meet it, so that's great. And at the end of this, we'll have some additional tools that can help you to ensure that you are correct. And then, of course, the second option is just throw it out and start from scratch. And to a certain extent, I think this one's almost easier, especially for the 21% of you that don't think it meets and for the 14 of you that are not sure. You're better off just starting from scratch, understanding the pen, and then applying it and developing it, writing the policy that meets your specific center and patients. Because taking someone else's, you can get some ideas, but typically what happens is that there'll be language in there that the center is actually not complying with because it doesn't even apply to them. And in your case, you've got a very unique situation like your migrant vouchers that you offer and those types of things that aren't in some other centers' policies and procedures. So I've got about a 4-step to go through here with you. And again, these are just guidelines, and the purpose of the presentation was for you to have a tool afterwards that would help you to go through and remember sort of how to accomplish this. But, first step number 1, obviously, is you've got to evaluate your current patients. You can use a need assessment there, your focus groups, your consumer board members, your staff feedback. Those are all important in not only evaluating your current patient, but also determining, what is that appropriate nominal fee, as we talked about. And you need to make sure that you consider the unique characteristics of your target population. You can't have different sliding fees based on population, but you've got to take your unique characteristics of your population into consideration as you're developing this. And an example would be if you've got a self-declaration for patients that are migrant, they're moving from one area to another for work. They don't necessarily think, oh, I'm going to get sick, I need to take my tax return with me when I go over to this town to work. So you may have to consider and put things into your policies that are specific to those targeted populations that you serve in order to ensure that it's not a barrier to care for them. And then, of course, you need to ensure that your sliding fee, addresses the fee schedule. It addresses the different discount schedules, the eligibility criteria. And again, these are checklists for you, so I'm going to go through them pretty quickly here. The sliding fee discount structure needs to have at least 3, as we talked about, between 100 and 200%. Establishing your collection and nominal charge, as we talked about, determining what that is from the patient's perspective. Ensuring that your patients with third-party coverage are not excluded from your sliding fee, which is a common error that we see. And then, of course, having the multiple sliding fee discount schedules, as we talked about, such as dental, vision, if you do offer that, if you've got a mobile school unit that's outside of your clinic, that type of thing. And then, of course, for the formal written and referral arrangements, that you also ensure that the sliding fee discount is in those arrangements and that those are being monitored, and we'll definitely discuss that in more detail. And then other considerations, as we talked about, things that you can provide at cost, such as your dentures, that would, of course, would be separate from your sliding fee of charges. Your drugs, medications that you're providing, that type of thing, and we'll discuss a few examples of that as well. And then, of course, ensuring that your board approves those policies. If it's not approved by the board, it's not legit. It's approved, ensure that they approve the federal poverty guidelines annually, which again I'm sure a lot of you doing. But just a reminder, include that in your list of items to do at your board level for the month. So if you've got a calendar of events, updating that. And then, of course, updating it in your actual systems as well. And then evaluating the sliding fee from the perspective of the patient. I'll keep talking about this one because this one's such a significant component of the new PIN. And again, this one here, a best practice is annual, but at least every 3 years, and your budget period renewal or your competitive bidding process now is every 3 years. So tying it with your 3-year renewal process, of course, will allow you to be compliant if you think it's too much of a burden to do on an annual basis. And then implementing those operational procedures and relating to the board, so staff training, updating your systems as we talked about, and notifying your patients of the sliding fee. We'll discuss some more options of that. Updating your forms, notices, websites. A lot of times what we'll see is it got updated on one side but didn't get updated on the other side. So the notices that are still in the waiting room area are old, or the website has old notices on policies and procedures. And here what I really recommend is, when you have those notices and those types of things, refer, as opposed to articulating all of the policy again, refer to the policy so that when the policy is updated, you don't have a conflict. That's the best way to accomplish that. And then one real important thing I think that helps you as a center is include it as part of your QI plan. Just have that as part, a sliding fee as part of your quality improvement plan. And you know, whether you take a sample of 5 or 10 patients each month or quarterly and evaluate to ensure that you're in compliance with your policy. That's an easy way to monitor, an easy way to see if you've got a problem, and it really does show compliance and oversight from the management's point of view, and it also then will show oversight from the board's point of view if you're taking your QI plan and results to the board, so it allows you to accomplish all 3 objectives in one. And then, of course, training staff. Again, you can just never train enough. With the sliding fee, there's so many areas to go, to go wrong because you're depending on patients, and they're ensuring that they're going to bring all the proper documentation, and then you're counting on staff to interpret that documentation correctly, document it in the paperwork, and documenting in your systems. So there's a lot of areas to go wrong when I do the single A133 audits and do sliding fee sample testing. There always seems to be findings on this one because, again, there's so many areas that can go wrong. But a QI plan is a great place to ensure that you're at least monitoring it, and if you do have problems, you can identify, is it one staff member that we need to train, or is it the system itself, or are we just not communicating to the patient on what they need to bring, or what we're asking them to bring not appropriate. That's where developing the policy to be specific to your unique characteristics of the patients that you serve is very important. And an example of that is asking them to bring, for example, proof of residency, and that is from someone else's policy that requires that, but your policy may not require that or may not be important to have as a board. So you need to determine if that's something that you require to have and want to have as part of your eligibility criteria and not someone else's. So with that, let's go to polling question number 3. I know that you've had a lot of material thrown out at you, and I want to unpack step number 2, but just want to see if you need to take a little break right now or if you want me to continue going.
Looks like majority want to continue going on with the presentation.
Great. Great. Then since 75 want to continue, we will continue. That's great. So let's start unpacking number 2, step number 2. That's really the important one. And that's developing and determining what needs to be into each of the components. So your schedule of fees, this one, your charge master, even though this one is part of typically of your billing and collections policy, these components are really important to be in your process of developing, because as you start your sliding fee, you've got to start with a schedule of fees. And again, in your policy, your sliding fee policy, you would state, and my recommendation would be is you state that you establish a fee schedule, that the board establishes a fee schedule, and that the criteria for developing that is outlined in policy XYZ, billing and collections, and not that you then articulate your process there, because if you do it in both policies and then you violate and change one policy and don't change the other one, you now suddenly have a conflict in your own policies. So when you have a reference to a section that is in another policy, my recommendation is just refer to that policy. But in your sliding fee, you want to say that you have established fee schedules that are approved by the board and that reflect cost and your local market factor. So it covers the cost, as we talked about. It includes all of the services in your project. And this is really important. You have to ensure that you've got a CPT code for all of the services that you provide. Your sliding fee needs to be consistent with that local prevailing rate. So here an example, and I'll use one that is very easy for people to understand outside of, still in healthcare, but outside of our industry, and that's, for example, when you go to a hospital and you get a bill and you've got a charge for an aspirin that's $100, and you know that an aspirin costs $1 to buy a bottle of them. So again, that would not be a prevailing rate. In your circumstance, it would be whether you've got certain office visit costs or charges, that you have a local competitive environment where the charge is much lower than what your cost may be, but you've got to adjust it for that local prevailing rate to ensure that it's within your market. And again, the objective of HRSA is that your sliding fee does cover your costs. Doesn't mean you're going to collect that amount, but that at least that charge, the objective of that, is accomplished. And when you have a relative weight given to the reasonableness of those costs, that it depends on each of your circumstances, each of your appropriate areas, and analyzing your specific situation. So again, using the UDS to look to see what your cost to charge ratio is, using your average top 10, 15 CPT codes in relationship to what your PPS rate is, because your PPS rate is supposed to reflect your costs. So if your charges aren't even there, then of course you'll want to adjust those. And making sure your policy gives you the flexibility to do that if you need to during the year without having taking the entire policy back, or the entire sliding fee back to the board for approval. Okay. And then, of course, your sliding fee program must include all the services, as we said. It must be established based on that patient's ability to pay. This is the very key crutches of this, is that ability to pay. And it needs to be uniformly and consistently applied to all patients. And it is only based on family size, income, and no other factor. Here you need to definitely make sure that you don't have language in your policy that says it'll be offered to patients that do not have any other coverage. I will see policies where it will state in the top thing it is offered to patients based on family size and income, and then somewhere down in the policy it'll state, if patients have insurance, this doesn't apply. So again, you've got to look at your entire policy. That's why I'm saying to a certain extent it's sometimes easier to throw it all out and start from scratch and include all of the components that you need versus trying to adjust your current one. Or if you do, make sure that you are articulating reviewing and articulating each of the areas to ensure there isn't conflict within your own policy. And then, of course, your sliding fee discount must define the eligibility criteria. Who is eligible? It's income, so you're defining that income, and when you're defining that income, you're determining, what is included in that income. Your family size, who are you going to include? Does it include adopted kids? Does it include foster kids? Does it include mom and dad if they live with them? That type of thing. And then what documentation? Here again, what documentation are you requiring? HRSA doesn't tell you what needs to be there. It tells you need to define it and determine what it is. So what is it as an organization that you want to include in that proof of income? And then, of course, the renewal process of it. But keeping in mind, when you're determining that income, proof of income, take into consideration your specific population, especially the ones you serve, in your case, a very unique population in your farm workers. And then you must have supporting processes that are in place to be able to assess this. A lot of times you can come up with a beautiful policy, but then it just isn't practical. So I recommend when you do start working on this, or if you're evaluating it, include the people up front that are actually implementing it. They're the ones that are going to operationally process it, make sure that they have the ability to see how practically they're going to accomplish that. in evaluating the household and the patients. So what we see here, especially when I do the audits for single audit for the A133, is that different people are using different amounts for the income. So it may have a tax return as an example, and one is using gross income, one is using net income because it wasn't defined or specified for them. It just said provide a tax return, and it doesn't specify to the employee, the staff member, on what line item they're supposed to use to determine that. Okay. And again, making sure that it is culturally appropriate, it's respectful of the patient and appropriate in your specific circumstance. And then, of course, individuals and families with annual income above the 200% are not eligible. So keep in mind, this is 201. I've had, in my reviews, I've had one clinic have a 19 out of 19 on their program compliance, and one of the requirements, they almost didn't make the sliding fee because they had the word that didn't include the 200% patients, but they caught it just the week before we came on site and they fixed it. But this is a very easy one to really fall trap to, because it includes the patients that are 200% in the discount, but patients that are 201% and above are not eligible. So they may have other sources of funds, though, that they can be eligible for, and you can define that in your policy. Okay? Your sliding fee structure must offer discounts, or basically they must receive a full discount or this nominal charges we talked about for patients that are 100% or below. And I know there's a lot of repetition here, but we're again going through the structure of this, so these slides will hopefully, as you build it, will help you to just remember to include these components, to evaluate these components. And then at least having 3 discounts classes above the 100% to 200. So that is something the PIN has clarified. You've got to have 3. And again, this can be a percentage between the 100 and 200, or can be flat amounts as well. It's only the fee, the nominal fee, or the zero discount, I mean the full discount for patients that are 100% or below. But for your fee schedule or classes between 100 and 200, those can be a percentage of your charges, or those can be flat amounts. And of course, there's benefits to both, but the benefit, of course, to flat amount between the 100 and 200% as well is that it's much easier to collect and for your staff to implement than it is as a percentage of charges. But of course, that's up to your discretion. It's up to you to determine what those are and how to offer them. And then the nominal charge, it must be a flat fee. So for those patients that are 100% or below, they're either paying 0, they have a full discount, or there's this nominal charge. And of course, the nominal charge is not supposed to be reflective of that cost. And it is supposed to be nominal from the perspective of the patient. And I know there were some questions on that. So I'm going to flesh out a little bit more from the perspective of the patient and how to create that, because that is intended not to be a barrier to care. So in your policy, when you're going through it and reviewing it, make sure that you don't have the word minimum fee, minimum charge, or copay. Those terms would make your policy non-compliant. It needs to be referred to only as nominal, and it needs to define how you're going to determine that it's nominal from the perspective of the patient. And so let's discuss those options, because I think evaluating that and documenting that is really becomes the crutch of what you need to accomplish that. So, let me just go back one more here. So let's discuss that a little bit here on the options that you have as a community clinic. To determine it's nominal, you have ability to be as a community center and an FQHC. You've got a consumer board, so you've got a focus group of consumers within your board. So my recommendation is use those consumer board members as a subcommittee to assist and evaluate whether that amount is nominal. They are users, they know, they are made up of your patients, so they'll be able to help that. You can do patient surveys, obviously, but be careful how you ask the question on your survey, because, you know, based on your question, you may get an answer that you may not want. So if you ask the patient, you know, is this amount too much? You may get yes, because that may just be how you phrase the question. So make sure you phrase the question in obtaining a true ability of determining what that amount would be as a barrier versus just that they don't want to pay it. Because not wanting to pay is not the same. Refusal to pay is not the same as ability to pay. Those are two different things. Another way is evaluate and do a survey of your staff. They're the ones working with the patients. They know whether those are difficult, if they have difficulty obtaining and collecting on those amounts. Look at your bad debt. If you're currently collecting 90% of your amounts up front, or, you know, afterwards, regardless, if you're collecting about 90%, then probably your nominal amount is not a barrier of care. So establish what that baseline is and then evaluate to see, you know, if we're collecting only 10% of our nominal amount, then that's probably a high amount that it's too high. We'd be better off collecting 50% and only charging $5 instead of $20 as an example. So evaluating your bad debt, establishing a base, and then determining if you're being successful or not on that would help you also determine if it's a barrier to care. And here's my recommendation to you. When you write your policy, ensure that you outline that you're going to accomplish and evaluate your nominal amount from the patient's perspective using a variety of A, B, C, and D. You know, you could use a combination of. Don't only limit yourself to one option, such as, you know, doing a patient survey or focus group. Don't limit it only to that, because that may not give you enough information. So in your policy, my recommendation is document a couple of options. You know, we are going to evaluate the nominal fee from the patient's perspective using a combination of either and or A, B, C, or D, and that could be evaluating your bad debt, evaluating your patient's ability to pay at the time of the service versus after, doing a patient survey, doing a focus group of board members. You know, so have a variety of ways that you're going to accomplish that, so that way you have the ability to look at additional information and not skewed or isolated information. And then that's the information you use and take to your board for them to evaluate if there is an issue, and for them to be able to accomplish their objective on meeting their goal and their responsibility of evaluating the sliding fee from nominal amount from the patient's perspective. I know that was a handful here and a mouthful, but I think that should help you to determine and to evaluate that piece. So next, patients with third-party coverage. This one's really important because, again, like I said, we'll see that it typically allows people to have this misconception that the sliding fee only applies to self-pay patients, and that is not true. It applies to any patient that is eligible, and eligibility is defined by income and family size that your board determines and approves based on your policy. And then of course, you know, if your policy excludes these patients, you are automatically non-compliant. So be very careful to ensure that your policy does not exclude those patients. And then, of course, ensuring that you complied with any potential legal or contractual limitations. So you may have something in your third-party contract that says you cannot offer another discount, or you cannot waive a deductible or a copay or whatever it may be for patients that have third-party. So you'll want to ensure in your policy that you state that, you know, you will offer a sliding fee to all patients that are eligible based on income and family size, regardless of what coverage they may have, as long as it is compliant with any contractual obligations that their payer that you may have with their payer. So that would be something you would want to put in your policy to ensure compliance. And then the next one here is your sliding fee must apply to all the services. A lot of times what we don't see in your policy is that it defines what those are. And sometimes it's easier to define what is not included. So it's all services except for A, B, and C. That may be the easiest versus defining all of them. But the PIN does require you to ensure that you are providing a sliding fee for all of those that are within your approved scope, whether you provide them, whether you send it out to someone else, or whether you contract by referral and pay for it, or whether the patient pays directly to the referring provider. So I think, again, regardless of the type of service or the mode of delivery, you're required to have it if it's in your Form A 1, 2, and 3, columns 1, 2, and 3. And then, of course, we talked about having multiple sliding fees based on that service and mode of delivery. So not population, but service and mode of delivery for clarification purposes. And then next here, let's go through really sort of, I think, the one that's probably the hardest one for centers to try to implement, and probably the one that's the PIN clarifies more and expands on. And that's the ones for Form 5A, columns 2 and 3. So columns 2 is where the center provides the service and pays for it. So the voucher is a great example of that, where you're actually paying for it. So your agreement with that provider needs to state that you're paying for it and that the patient will be eligible under your sliding fee program. And then within your sliding fee program, you need to articulate what it is and how it is that you're going to provide that slide to the patient. Now, of course, if you're providing a patient a voucher, they're not paying anything for it. You're just having to articulate that. So the question would come into, what if you have a patient that you're giving a voucher to, and that patient is between 101 and 200%, then you're going to have to articulate whether that patient's got any responsibility or not, or whether it's going to be 100% paid for. You're going to have to articulate that in your specific sliding fee policy, which you may not have right now. Or maybe you're only giving vouchers to patients that are 100% or below. And then if that's the case, you then have to make sure the provider has another mechanism for the patients that are between 101 and 200, which can be extremely confusing. So you've really got to have to flush through this and work through with your staff and with the providers, and again, most of them are probably you're gonna have a hard time to get them to cooperate, because they're not the ones that have entered into agreement with HRSA, so they're not the ones that have to comply with this. But yet this PIN says you as the entity needs to ensure that the center is complying with the criteria, and the criteria that they define here is that it has all of the requirements of PIN 2014-02. And that patients below the 100% are only charged that nominal amount, and that they meet that criteria of the 2014 PIN, and that it's uniformly, it's applied to all patients equally, and that, of course, you routinely evaluate that your sliding fee is being compliant with, and that this is from that provider's point of view, or from the patient's point of view regarding that provider. And we can talk a little about some options that you can do and how to track that and document that, because I think, again, that's a bit of a challenge, but we can probably make it easy for you with a few things, adding a few things to what you're already doing and to comply with that. Because your board here, again, is required to ensure that it isn't a barrier to care. The whole objective of the sliding fee PIN is that it provides services to patients, and it does not provide a barrier to care for those patients that are below the 200% of the federal poverty guidelines. So let's talk about the formal written contractual relationship arrangements. So for your MOUs, contracts, whatever it may be that you have with providers that fall into column 2 and 3, you are now, as an organization, required to ensure that they comply with this PIN 2014-02. And this is where, I would love to probably ask that polling question again and see if the same 64% still feel that their policy is in compliant, because this one is a real tough one to try to accomplish. And here you want to ensure that those services in column 3, where you have a better ability to control the ones in column 2 that you're paying for, but for the ones that are in column 3 that you're not paying for, you're going to have to ensure that the contract, you're going to have an amendment to your agreement, whatever it may be, that are now in compliance with this PIN. And the PIN gives you 2 options. And here's the criteria that has to be, of course, outlined if you do have that agreement with them. And that, of course, is that they provide the discount to patients at or below the 200%, and that the patients that are 100% or below receive no charge or nominal fee. And, of course, most referring providers are not going to be too excited about this. In the past, most of the requirements were that you as an entity had language in there that stated that they would provide a sliding fee discount, but it never specified what the criteria was for that sliding fee. And now this PIN does say that it does have to be clarified, and that you as a center have to ensure that you're overseeing and monitoring this. So here are your 2 options for these referring arrangements. The first one is that the referring provider sliding fee meets all the requirements. Like we said, it has the 3 classes. It provides sliding fee between the 100 and 2%. It's free or nominal for those below the 100%. And that it includes all of the structure requirements as specified on page 10 of the PIN. Or your second option is that your referring provider provides a discount that is better than yours. So you are allowed to enter into an agreement in which the referring provider offers a better discount than yours. And if that's the case, then they don't have to comply with the provisions of the sliding fee. However, keep in mind, of course, if you do provide, and I just noticed, got a little on it's PIN 2014-02, not 01 in my second option there, so my apologies for that. So we are talking about PIN 2014-02. So there, as long as you offer a better discount, they offer a better discount, then they do not have to comply with that. And this was clarified by the HRSA policy team on what the PIN is saying. So your 2 options are, you either ensure that they meet all of the requirements of the PIN, or that they offer a better discount, in other words, greater discount than what you would be offering as a center to your patients, and then they don't have to comply with those terms. So those are the 2 pieces or 2 section options that you have in order to comply with this referring arrangement that we talked about. So that's quite a lot to digest. So I'm sure there'll be probably more questions on that. I'm going to go ahead and continue because we want to open up to questions and leave time, as much time as possible for questions. So I'll quickly go over other considerations here, and these are things that you can charge the patients and can have a different structure, such as for your supplies and equipment. So if you do EKGs or you do x-rays, or you have a pharmacy that you're offering or whatever it is, you may be able to have, and here's some more examples, eyeglasses, dentures, prescription drugs, those types of things. You can definitely have a charge to the patient. You can offer it at cost plus an administrative fee there. Obviously that's reasonable because that's part of your cost. And people don't always think about including that little component, such as your pharmacy. If you do provide 340B pricing, you need to, you are allowed to include your administrative cost in that dispensing of that pharmacy drug, because that's part of your cost. Or if you've got dentures and you're having to pay outside of that. But the important thing here is making sure that those amounts and costs are identified to the patient, that the patient knows what they are before they actually incur the cost, because typically these are costs that are optional for the patient. I mean, prescription drugs obviously would not necessarily be optional if they need antibiotics or whatever it may be, but the point being is that the patient has the option, especially for the supplies and equipment, whether they want to do that or not, and what that cost would be to the patient. So your policy needs to specify and outline this as well. And then, of course, the last piece of this pen, which we did not go into a lot of detail, and like I said, that would be a whole other session, and that's your billing and collection. That's program requirement number 13, and that's also part of the PIN 2002, and it has to be evaluated and also updated. So you want to make sure that not only are you looking at your sliding fee policy and procedures, but you're also looking at your billing and collections to update that for PIN 2014-02. And with that, let's go through to our polling question number 4. Audrey, are you there?
Yes, I'm here. Can you see the question?
Great. I sure can, yes. We've got about 13%, 20% voting. Great.
Okay, we'll go ahead and
So
that one.
So the answers or your options here is yes, you've had an OSV from HRSA and you did not meet the program requirement number 7. The next option is you had an OSV and you did meet the program requirement, or no, you have not had a HRSA visit, and or no, you anticipate to have one within the next 12 to 18 months. So here is the results of that. We got 43% of you that voted, and we've got 40% of you saying that no, you you anticipate to have a HRSA site visit within the next 12 to 18 months. You have not had a HRSA site visit, and you anticipate to have one pretty soon here. So there's quite a lot of you that fall into that category. So this is hopefully timely and can be helpful for you to ensure that you are one of those that did comply with the program requirement number 7. And 20% of you said you did have an OSV visit and that you did meet the requirement. And congratulations, you are definitely on a list of prestigious grantees, because this one is definitely a tough one to meet. And 10% of you said you did have one and you did not meet it. And then 30% of you said no, that you've not had one, and you have not had an OSV. You have not had an OSV visit, so you're really not sure at this point if you're compliant or not with it, but you don't anticipate to have a site visit in the next 12 to 18 months. So the majority of you are going to be having to deal with this sliding fee PIN, and hopefully this is timely to allow you to get it compliant and be part of that additional 20% above. So congratulations to those of you that are 20% above. So with that, let's go through how we can help the 40% of you that are getting ready for that site visit, and those 20% of you that have already gone through the process. Just bear with me here. This one is really sort of one of those that, to me, the best tool that helps you to ensure if you're compliant is really, really, really the tool that's used by HRSA, the one that the team that comes out. What do they use and what do they look at? And if you can answer these questions, and of course there are significant components within these questions, but if you can answer these questions, this helps you to ensure you're compliant. So the next 3 slides really just go through that. And they're going to be a lot of repetition, of course, because, again, this is, consistently the same material over and over, sliced and diced in different ways. But, here, go through and asking these questions. At a minimum, does the following areas in your sliding fee address? Written board-approved policies that support the operational procedures, and this is how they define that. Does your policy have the definition of income and family? eligibility for the sliding fee discount is based on income and family size and patients and no other factor. The methods for making the patient aware of that. So how do you identify or notify the patients? Is it an appropriate language and literacy level? Documentation and verification requirements to determine that. The frequency of reevaluating the patient's eligibility. So they're asking, are all these pieces in your policy, and are you obviously following them? And then your structure of your policy. Does it have all the required structural processes in it? And then evaluating that, of course, at least every 3 years to ensure that it's not being a barrier to care. And this one is, of course, the challenge. So on the sliding fee income, this is on the next slide, reflecting the current poverty guidelines. It's asking you there again, do you have patients that are 100% or below the federal poverty guidelines receiving a nominal amount? Is there 3 discount classes between the 100 and 200? Do patients receive a full discount for the ones that are 100% or the nominal charge? And if the health center does have a nominal charge, back to how do you evaluate that nominal charge? So this is where it's really important for you to determine this, and that's what we talked about here, having a focus group, having your board group, having staff question for the referring providers. Part of your referring process is following up with the patient to see if they got the referral and if there was any issue with the sliding fee or the amount they had to pay as a way to evaluate that. Looking at your bad debt and seeing how much you're collecting or not collecting. So all of those would fall into the next 3 bullet points here on determining that nominal charge from the perspective of the patient. And then the next one here relating to your Form 5A, columns 1, if it includes all the services that you're supposed to be providing, and then of course column 2, Form 5A, column 2, the ones that are part of your contractual arrangement that you're paying for, and if you've got written arrangements that include or describe that sliding fee component of it, and then of course your column 5A, your Form 5A column 3, which is really the crux of the one we just talked about, where you're not paying for it, but you're referring to that provider and ensuring that they either provide a better discount, or if they provide a sliding fee discount, that it meets all of the requirements of the PIN. So these last 3 pages is what will help you to ensure that you're in compliance. I think that's your best tool to allow that to accomplish. And you can find the whole guide. The last page of the presentation gives you resources and the website to find that guide for the 40% of you that are in that process of having a site visit coming up. So that gets us to poll question number 5, and then we'll open up for questions. So, was this training helpful in assessing you understanding the program requirement number 7? And it's a yes or no, and need more help. So if you go ahead and we got a 50% of you. And we currently have 100% saying it was helpful, so that's great. Great, so that is wonderful. I think now what I'll do is I really thank you for your time. It's very difficult to do webinars where I can't actually see your visual expressions and your feedback. But we're going to do our best next as we open for questions to try to answer your specific circumstances. If there is any questions where I may need more information on your specific circumstance to answer it so that I do not mislead you in any way, I'd be happy to do that after the conference at a different scheduled time, and you can email me. My email is on the second page of the slide, because I want to make sure that I answer your specific question to your specific circumstance. So the answer may not just be a yes, no, or it may apply in one situation and not in another. So I want to be very cautious to make sure that I'm responding in a way that's specific to your situation. So with that, Auburn, can we open up for questions?
let's see if we have any. Okay, this one says, thank you so much for the webinar. It was very informative. I attended with 4 of my staff members. One question, we love your accent. Where are you from?
Oh, that's so cute. That is not in the pin. Thank you. I was born in Portugal. I grew up in South Africa, spent a lot of time in Australia, and went to school in the U.S. and been here having my 27th wedding anniversary with a wonderful, wonderful, sweet, hot American husband. So I don't know where I'm exactly from. I've sort of been everywhere. But I definitely claim to be American. I'm an American citizen and have been for 25 years. So thank you.
This is from Marco. He says, are supplies and equipment considered services in scope?
Well, it depends on the supplies and equipment. So if you're talking about swabs and those types of things to provide, an office visit, an injection, that type of thing, it is. But if you've got supplies that are outside of that, so crutches, for example, or medications, or, for example, equipment such as machinery that you're doing an X-ray with, or EKG, or an echogram, or those types of things, those would be outside. Does that help, Marco?
Okay, bridges, lenses, etc.
Bridges, lenses, yes, that would be outside, correct. You could have a separate fee schedule for that, or fee costs outside of your fee schedule.
Okay, and we have one from Terry. Can bad debt be forwarded to a third-party collections agency regardless of the income slide eligibility?
That is a very good question. That would fall in your billing and collection process. That really is a decision that's made by your board. The sliding fee on billing and collection, which starts on page 13, doesn't specify that you can't. It says, you as a center have to make your best ability to collect and to bill and collect for those services. And just how aggressively you determine that really would be based on your own policy. You have to keep in mind, again, the patients that you are serving and the difference between determining their ability to pay and their, unwillingness to pay. So it's very important, I think, to define those two criteria, if they're not willing to pay versus if they don't have the ability to pay. But that would be something that you would want to define in your billing and collection policy, and definitely something that would have a whole another seminar on, another webinar on the billing and collection component of it. So that's up to you as a board and an organization, keeping in mind your patients that you serve. You're welcome, Terry.
This is from Carla. It says, when is it that the CHC must have a full discount sliding scale?
And maybe, Carla, if you're asking if it changed, it didn't really change. This pin just clarifies. It's saying that you have to have a full discount for patients that are 100% or below, or a nominal fee. So you can charge them a nominal amount. And I don't know how to answer you as far as if you're asking if there's a date or if there's a change in policy. Did it change at some point? But did that answer your question? Okay, great, Carla. Any other questions?
I don't see any others. Let's see. looks like you've answered all of them, Lucy, as of now.
Okay,
Yeah.
great, great. And so I think, we may be a little ahead of time, but that's okay. We wanted to leave time for questions. This definitely is a lot of material to digest, and it definitely probably feels like a lot of repetition, but it really, to a certain extent, is assisting you and hopefully giving you the tools to evaluate where you're at. If you do have subsequent questions, do feel free to contact me. I'll do my best to try to answer those for you. I will be celebrating my wedding anniversary, as I shared with you, in the next couple weeks. So if you do contact me and do not get a response in the next couple weeks, you'll know why. But typically I will try to respond to you. Probably will have to call you back because a lot of times I'll need a little more information to be able to answer your question. I do wish you all the best, and I hope that all of you can be added to that 20% that met that requirement. And you can say it was because of this great seminar that the National Center for Farm Workers Health put on today. I thank you for your time and look forward to talking with you again, and wish you all the best. I know you're doing a lot of wonderful work out there, so keep up the hard work, and thank you for your time.
Thank you, Lucy.
You're welcome. Thank you, Arben. So I think we will close down now at this point. And
yes.
Great. Okay. Thank you, Arben, and thank you, everyone that's still on the call, and we'll talk later. Thank you. Oh, okay. Could you email us slides? There was someone that asked that.
Okay.
Arben, I don't know.
Yes. And I can put
okay.
those to you, yes.
To them. Great.
Perfect. Okay.
We'll just wait. There's 15 more people, so we'll just wait a little bit and make sure there's no other questions or... Thank you, Hilda.